Rena Clement, and I would like to thank you for joining the Oncology OnTrack webinar series today. If this is your first webinar with us, we offer webinars about every other month throughout the year. And if you visit our website, priorityconsult.com, you can find a list of upcoming events. Today's webinar, Survivorship Program Planning for Commission on Cancer Accreditation Compliance in 2015, is focused on cancer survivors and survivorship care planning. The presentation will specifically provide you with the information you need to prepare for the new CoC Accreditation Compliance Standard going into effect January 1st. Our speaker today is Teems, Consulting Principal and Founding Partner of Practice Advantage. Before Cam gets started, I want to take a moment to invite you to mark your calendars for the second annual Priority Consult Workshop. The workshop is scheduled for September 25th and 26th in Indianapolis, Indiana. Attendees will spend a day and a half immersed in oncology issues, such as what to expect during your Commission on Cancer audit visit, and additional information about survivorship programs. Registration will open July 1st. I hope you will plan on joining us. If you have any questions during the presentation, feel free to type them in the chat window, and they will be addressed at the end. Without further ado, I'd like to once more thank you for joining us and pass things over to Cam.
Thank you, Katrina. Okay. All right. Well, welcome, everyone. Let's start with the things that I have on our roadmap of items to cover during today's webinar. So today, during the next hour, my goals are to provide you with some background on why there is a new survivorship standard for both the Commission on Cancer as well as coming for NAPBC, and then to talk about the components of that standard and how to address your own plans for compliance with that standard. And so, of course, the start of that is, who is a survivor in your current patient base? What is the definition of a survivorship plan? What are the requirements specifically for your organization if you are accredited by the American College of Surgeons and the Commission on Cancer, and the specific standard related to survivorship, which is Standard 3.3. What are your patient's rights as it relates to survivorship, and then whether or not you need to form a specific survivorship clinic in order to make the adherence to the survivorship standard easier for you to manage, or just specifically as part of addressing the standard, will you find that the building of a survivorship clinic is a natural next step for your organization? And what does a survivorship clinic look like? How does it behave? Does it generate additional revenue? What are its benefits, etc.? And then we're going to talk about the different providers of survivorship plans in the United States right now, and those are from the Institute of Medicine, the American Society of Clinical Oncology, Journey Forward, Livestrong, and of course we will talk about Oncology OnTrack as the sponsor of today's webinar, and how if you are an Oncology OnTrack user, how you can easily use Oncology OnTrack to access and create a survivorship plan for your patients with information that is already inside of your Oncology OnTrack database. Okay, so those are our high-level plans for what we're going to talk about. All right, let's get started. So first of all, the background on why there is a national plan for addressing survivorship and survivorship plan access in the United States. So there was a study that occurred by the Institute of Medicine that looked at the state of patients who had completed their cancer treatment and were deemed survivors. And that report had several important results as part of it. Of course, the number one result of that was that there are a large number of cancer survivors in the United States currently. And as they surveyed those survivors, they discovered that many of those survivors felt lost in that survivorship environment. Many of them felt anxiety as it related to recurrence. Many of them felt as if they had a comfort level during the treatment process because they had ongoing appointments with their treatment providers. But when they transitioned out of that, what can be a secure environment of treatment, and went back to their primary care provider, that added to a sense of insecurity for them. It also added to a sense of insecurity as it relates to those primary care providers who are then in a position to treat those patients who have survived these many different tumor sites. When they surveyed those providers, many of them said that they were not prepared in either never treated the late effects of those survivors in their patient pool, or that they were not prepared to handle those transition issues. And so some of them were, of course, but many of them did answer with never, rarely, or sometimes. And this, of course, caused the Institute of Medicine to say that we need to better prepare the providers who are treating our survivors, as well as provide information to the survivors about what happened to them during that treatment process and how for them to manage that information as well as the plan that has been provided to them. And so at this point we have the obstacle that's been identified, which says that we have this large pool of survivors in the United States, and we have a pool of providers who are potentially ill-equipped to support those survivors. And so, and in addition to that, there are things like the lack of awareness for the need for survivorship plans for those treatment providers. So the treatment providers were also saying they did not feel like that there needed to be a terminal point in the treatment plan, which then gave the patients as well as their providers a snapshot of what had happened in the past and what needed to happen in the future specific to that survivor. The treatment providers talked about the lack of time to create such a plan, and of course voiced their concern that there at this time there is no reimbursement for the additional work as it relates to survivorship. They also pointed out that there is no standardized framework for what needs to be in a survivorship plan, or was no framework at that time, and it was not, in anything that was out there, was not focused only on cancer surveillance and not survivorship. And that there was really just a lack of information and validated research about why we needed to have any organized survivorship plan in place for all cancer survivors. So we have about 12 million Americans living with cancer, as the data pointed out, and that's about 1 in 10 American households with someone. So not only are there people living with breast cancer, or with cancer in general, their families also went through that treatment process and need to be part of that survivorship process as well. And we know that once they reach the terminal point of that treatment, that there are lifelong effects related to a cancer diagnosis that need to be dealt with. And survivorship planning is a great way to deal with those things that are often do go ignored. Go unaddressed and ignored. Okay. All right. Okay, so let's start with who is a survivor. That is, I have a lot of people ask me that question. There's a lot of urban myths as it relates to who is a survivor. Is a survivor a patient who has completed active treatment? Is someone only a survivor when they reach the 5-year mark after their pathological diagnosis of breast cancer? There are many different ideas out there, and this is the information that we have today. So first of all, it is someone who did have a diagnosis of cancer, and the second thing that is important for me and probably for most of you on the phone is it is a patient who has completed her or his initial treatment. And for many patients, like breast cancer patients, for example, who go on for 5 to 10 years post completing their radiation or chemotherapy, we certainly don't want to wait until that 5 or 10 years is complete in order for them to be considered a survivor. So this is an important point. So I think that it gives us a great point to define that a patient is a survivor once that treatment has their main initial first or second or third course of treatment is completed, and then if they have long-term hormonal or endocrine therapy, that occurs in parallel to a survivorship plan. Also, a survivor can also be defined as a person who lives 5 years beyond diagnosis, and that's been the standard definition. But for the sake of survivorship plans and when to kick off providing a patient with a paper survivorship plan, it's this portion of the definition that's going to be important going forward. Okay? All right, so now let's move on to, there we go. All right, so I want to talk about the survivors' rights just quickly. So the Institute of Medicine has determined that survivors have a right to a record of their treatment and to understand it. When they surveyed the patients in that study, many of the patients did not remember what had happened during their first, second, and third course of treatment and what treatments they had received, as well as specifically the names of the treatment types that they had received. They also have a right to understand about what should and has been recommended to happen to them after treatment, and that is, of course, their follow-up recommendations as it relates to ongoing screening or continued therapy, but also any potential late effects that are not currently present but could be present in the future. They have a right to understand what life will be like after treatment, a picture, if you will, of the future, how to stay healthy, recognize future symptoms that, again, at this point, at the end of their active treatment may not be present but could be present in the future, and how to deal with maybe current effects that may linger, such as the psychosocial or financial or clinical issues associated with that diagnosis. Even if the active treatment has been completed, we know that a diagnosis can be, quite devastating from a financial standpoint in some cases, as well as psychosocial and as well as clinical. And what available resources are available to them, either through your cancer center or nationally through websites, through local support groups, etc. All right, so now let's start with what is the definition of a survivorship plan according to the Institute of Medicine study and now the new Commission on Cancer standards that grew out of that study. All right, so those of you who have your updated Commission on Cancer standards, you see that standard 3.3 reads as follows. The Cancer Committee develops and implements a process to disseminate comprehensive care summaries and follow-up plans to patients with cancer who are completing cancer treatment. The process is monitored, evaluated, and presented at least annually to the Cancer Committee and documented in the minutes. So you're all familiar with the CoC requirements that if you have an active standard requirement, then of course there is also the active requirement that that standard and its execution within your center is also monitored on an ongoing basis by your Cancer Committee. And then of course that's documented in the minutes, so at your ongoing site surveys, that information can be obtained by your site surveyor. This is what the page looks like in the most recent set of standards. For those of you who have not seen it, and it just goes over that information that we just talked about and the specifics associated with what you need to have for 3.3 in your, if you are up for your site survey in 2015. They want to see that you have kicked off this plan, that you are beginning a phase in. You do not have to have an entire survivorship care plan in place with all of its components actively working and have been able to measure that by your Cancer Committee in 2015. They are clear that they are going to be phasing it in, and what they want to see in 2015 is that you have put in a plan for creating your survivorship care plans, and you have developed a process. And that will be what they want to see in the minutes and as part of their site survey should you see them in 2015. Okay? And that you are prepared annually to review that, those processes that you've put in place. All right. Okay, so these are those standard plan requirements. Again, it is and these are specific to the plan to be provided to the patient. And so I want to just talk about these for a moment. So they want the plan to be prepared by the principal provider who coordinated their treatment. Okay, and in some cases, in most cases, this survivorship plan in most newly developed survivorship programs, that survivorship care plan is prepared by a nurse navigator. However, that survivorship plan is of course reviewed by the supervising physician for that nurse navigator. In some cases, the survivorship plans also are even, some centers are having survivorship plans in the first year of existence, also having those survivorship plans reviewed by the breast conference providers as a way just to ensure that the plans themselves look like what the breast conference providers intend as the providers who were part of or represented the treatment plans for those patients. At breast conference or lung conference or whatever specific tumor site is applicable. You could also, if you wanted, multidisciplinary review of your survivorship plans, you certainly could have them reviewed at a higher level tumor board that represented all tumor sites. But that's just an idea. The survivorship care plan is given to the patient on completion of their treatment. So during that last patient visit after their last course of treatment, when often that patient is given the information that says that they can now go back to their pre-diagnosis screening protocol and that their ongoing health can be monitored by their primary care physician, then during that visit is typically when the patient is provided with their survivorship plan. It's also, because the survivorship plan does carry information about, as you see under C, their care that has been received. It's a great opportunity to go through because sometimes it can be over a long period of time, and patients often are say, gosh, I can't remember what happened last week, much less, what kind of radiation, whether I had brachytherapy or if I had external beam or what kind of radiation therapy I had, because it was 18 months ago. And I can't remember what I had for breakfast. So this is a great way for their principal provider, and again, that may be the nurse navigator or navigator that has worked with that patient throughout their entire plan. Their treatment plan, and brought them all the way through the process. So it's a great way to just go back through what has happened, the uniqueness of their diagnosis from the beginning, and then what their recommended follow-up plan is as it relates to screening, as it relates to ongoing access to providers. If that is ongoing psychosocial support, if it is compliance with a 5 or 10 year hormonal therapy, and the importance of that compliance, and then anything else that you would typically talk to the patient about at that point. If you want to talk to them about who is available to see them, their own primary care physician, or if your cancer center does have providers available who are available to see them in a survivorship mode. And so, of course, we'll talk about in a moment what a specific survivorship clinic is. At this point, as you're providing them with the survivorship plan, if you did have an organized survivorship clinic, then you could, of course, talk to them about what that means, and prepare them for what participation in that survivorship clinic entails. If, for example, they will not see the face of their medical oncologist any longer, but they'll see a non-physician practitioner who is aware of their treatment plan, or if the coordinator has been their surgeon, that you tell them that they will no longer be seeing that provider face-to-face, but they'll be seeing a designated representative who will make sure that that survivorship plan is followed, and will be closely monitoring them for adherence to that, and as well monitoring their screening as that relates to either ongoing imaging, physical exams, etc., to of course talk to the patient about their fears as it relates to recurrence, and how that is monitored in an active survivorship plan. And then, of course, to talk to them about the, any national resources that are available to them. Okay, so before that meeting with the patient, then, of course, the nurse navigator or that principal provider needs to have created that plan so that it is an easy piece of paper, and typically it is a piece of paper that can be handed to the patient, can be used as your talking points, and can be handed to the patient so they can take it with them and file it away at home for ongoing reference. All right. I have not to date seen anyone providing patients with thumb drives that include their survivorship plan, but that certainly is is a possibility if you are if your center is incredibly technically savvy as well as your patients. It certainly could be something that they can download at a later date if you have a patient portal that they have access to. But typically you like to send them out the door with something they can hold and touch, and while you're talking, make notes, and then of course refer to that later. All right, so let's talk about the resources for this piece of paper, this paper care plan that is essential to compliance with Standard 3.3. And really, from my perspective, it's an important thing. That's the topic of our conversation, which is the compliance. But I think it's incredibly important for the patient to have something in their hand when they walk away that helps them to know what is going to happen in the future, and to just revisit in their own way what they have been through. So at a minimum, there is a handout provided by the Institute of Medicine that can be easily downloaded and printed out and provided to the patient. And then there are a couple of manual data entry survivorship plans that can be opened on an active website that do require your nurse navigator or primary provider or support personnel to enter in the data that is required for a care plan that we saw just a minute ago. So that's everything that happened in their treatment plan, what kind of treatment they were provided, surgical, from a medical oncology standpoint, what chemotherapy regimens they were on, how many, what kind of radiation therapy they had, as well as whether or not they have any ongoing hormonal or endocrine therapy, and for how long, and how to have that have access to those ongoing prescription refills as they move on through that process, as well as provider names and locations for the providers should they move out of state or transfer their care to another provider. That way we can always go back to who the actual providers were. So it's not just what happened, but who executed those treatments. And then, of course, we're going to talk about Oncology OnTrack for those of you who are users, and how to access a care plan through Oncology OnTrack. So let's just go through some of these. All right, so the Institute of Medicine fact sheet is very comprehensive, and many centers that we work with like to provide the Institute of Medicine fact sheet along with whatever else they provide that includes the information that is specific to the patient. So this is pretty high level, and just about what to expect as it relates to cancer survivorship. So this is a very nice to have just to provide them with for reading at their leisure. Okay, so other choices are ASCO, or the American Society of Clinical Oncology, has a form that looks like this, that allows for easy moving through the form to hand enter information that reflects the patient's treatment plan. Also, they recommend that you provide a patient with a treatment summary that is not just this plan, but also information specific to the summary of their diagnosis type, so that they can refer to that later. The complaint about this form and other forms by many of the nurse navigators that we work with is, of course, it is time consuming to go back for each patient and pull all of this information in and re-enter it into this form so that it can be signed off and provided to the patient. But once it's completed, these are incredibly valuable to the patient. The other form that is very user-friendly, the ASCO form is user-friendly, and as well as this form, which is provided by a company called Journey Forward, part of the National Coalition for Cancer Survivorship. This one looks a little more pretty when you print it out. It has the background information related to their treatment plan, as well as the recommendations for their follow-up care, and it also addresses things that are not recommended. But you can see here it does have everything very organized about what happened to the patient. There's also a page about potential late effects that could occur based on their specific tumor site diagnosis. Okay, then there is the Livestrong care plan that is powered by the University of Pennsylvania's OncoLink, and this is, it's an ASP, it's a website that your nurse navigator or other provider can access and fill out, specific information about the patient. It's several fields that have to be filled out, and then this is what comes out at the end. It's a summary. It's just less table-like and more paragraph-driven. So this is what Livestrong's care plan looks like, with information that was entered specific about, this is an example for a breast cancer patient, how her breast cancer was treated, and about continuing her care. So from my perspective, it's really just about what fits your style, your center style, as it relates to providing something to the patient. Do you prefer something that looks like this, something that looks like this, or something that looks like this? So I encourage you to look at all three of those to decide which one is a fit for, of course, your style as it relates to providing your patients with some printed material, as well as weigh the pluses and minuses for the data entry requirements for all three of those, and your navigators and your staff who would be entering that historical data on your patients. None of these that I'm aware at this point allow for any type of interface or easy move of data from an EHR, etc., into these plans. They all require new data entry. Okay, that's the downside. Okay, so I want to talk a little bit about Oncology OnTrack. For those of you who are Oncology OnTrack users, this in order to create a survivorship plan that meets the standard, that includes both a treatment summary as well as the survivorship plan and surveillance recommendations for a patient. If you're an Oncology OnTrack user, you would open up the patient's, go to the print summary button, and you would choose her treatment summary document or his, and print that as part 1 of the survivorship plan. And then under the survivorship tab, after you have entered the survivorship plan as approved by her or his provider team, then that survivorship plan and surveillance document can be printed, and then these 2 items together form a cohesive and comprehensive survivorship plan that meets standard 3.3's requirements. Okay. Right. So there are other resources, not just the ones that I've talked about, for the care plans, but these are the links to the items that I've talked about today: the Institute of Medicine, the American Society of Clinical Oncology, Livestrong, and theirs. Journey Forward is in here, and then there are a couple of other choices for you to look at and weigh your options. Okay, all right. So as you have looked at the standard itself that says you must provide a plan that documents what occurred during the patient's treatment, as well as to provide them with information about potential late effects that have not surfaced, as well as their ongoing survivorship or surveillance plan as it relates to ongoing screening. And that can be imaging, provider appointments, etc. So these are a couple of things that I just want to mention to you that you might want to consider as it relates to thinking about whether a survivorship clinic might be a fit for your center. So as we help our clients now, one of the things that we look at right off is even if you are providing survivorship plans now, and many centers are already providing, many of them also are very familiar with the ACoS form and have been printing it out for years and providing it to patients. But one of the things that we see is that survivors are taking up patient slots on surgery. For your breast patients, they're on the breast surgeon's schedule as established patients, and they don't want to come off the schedule. They're on the medical oncologist's schedule, and because of the security associated with those treatment providers, they become established patients for years on end. And one of the things that we want to be able to do is provide fast access for our newly diagnosed patients. And if your survivors are taking up key appointment slots, one of the great ways to easily transition them gently when they really want to, when they are afraid of that transition back to a primary care environment, which many of them are, this is a great plan B for those patients, to build a survivorship clinic that those patients know is sanctioned by their current providers and reviewed by their current providers, either as the supervising or collaborating physicians to those non-physician practitioners, or you know, an oversight conference, much like your specialty tumor site conferences. We also recommend that there is a survivorship multidisciplinary group that meets and oversees your survivorship clinic if indeed you do find that it is something to consider for your individual center. So then, you know, do your survivors need special attention? And you know, when you look at this is where analytics are important. Do you have a lot of survivors who skew to a younger demographic, who do want to stay with their, you know, within the cancer center, and who, you know, would fall into, given their life expectancy, their recurrence does need to be monitored a little more closely. Do you have a lot of late effects going on where it would be easier to manage those late effects if those patients were monitored in a survivorship clinic? Do you have a large portion of patients who are on hormonal or endocrine therapy? We know from recent publications that compliance with those hormonal therapy is not where we would like it to be, and a survivorship clinic certainly would help that. And would be a great selling point to patients. And then finally, you know, I always say, ask your patients so that you can give them what they need and what they want. And you know, an easy focus group, a SurveyMonkey website that allows you to gather information about what your patients want and need. With, you know, simple questions. If we had a clinic for cancer survivors that monitored you, would you want to be a part of it? Would you want to be a part of it if it was not reimbursed by your insurance company? And if so, how much would you pay each year to be part of our survivorship clinic? One of the things that we're looking at is whether or not this is a great example of a new form of boutique medicine. For our non-Medicare beneficiaries who say, I really want to know that I'm being monitored closely for a survivorship, and I'm willing to pay for it so that I'm not in my general practitioner's office. And I think you'll be surprised to hear some of your patients say that they would pay, you know, in excess of, you know, $200 a year, for example, in order for them to participate in a survivorship clinic and know that their ongoing screening is being monitored. For example, I don't want to overuse the breast cancer survivor patient, but it makes sense that patients feel like, I want to know that somebody is looking at my mammogram and making sure that what the radiologist said is okay, that I'm getting an ongoing clinical breast exam in conjunction with that, and you know, that maybe somebody is looking at my other risk factors as well. And of course, that's of course not just for our breast patients, our colorectal patients. You know, as things change about their family, and if other family members are diagnosed and their potential for a hereditary syndrome increases, it's so much easier to catch that if a patient is part of a survivorship clinic. So if you look at those three areas and you do consider that a survivorship clinic is a way for you to really organize your compliance with this standard, then we of course recommend that you hire a non-physician practitioner to staff it, have the non-physician practitioner team have easy access to those survivorship plans as part of your EHR or your ongoing navigation program. It ensures your compliance. That practitioner team can have a leader who reports back to your cancer committee, as well as your survivorship multidisciplinary committee. They can also cross-function with any of your survivor support groups, and from our experience, it translates into high patient satisfaction and of course retention for any treatment for recurrence, as well as retention for ongoing screening services. So I think it's well worth it as you're considering something as terrible as compliance with the new standards, to also think about how best to put that compliance in place from an operational standpoint that helps your center from a patient satisfaction standpoint, and also can have downstream revenue that can help offset that, so that you can have a practitioner team in place. Okay, all right, so those are, I think we covered everything that we wanted on our roadmap. I know that it was a quick 46 minutes, but I did want to spend some time at the end being available to answer any questions that anyone might have as it relates to Standard 3.3 and the demonstration of your compliance in 2015. Are there any? I don't see any questions currently. Does anybody want to type any that I can see that we can address over the next 15 minutes? Okay. All right. Well, I don't see anybody on the Oncology OnTrack side see any questions that I'm not seeing.
Nope, not seeing anything on our side either, Cam.
Okay, okay, great. So if you have any questions that you that we haven't addressed as part of the greater presentation that you'd like to just talk about offline, specific to your own center and any of the items that we've gone over today, then you can.
Cam, sorry, I do see some questions now.
Okay.
You still have a minute?
Yes.
Okay, well the first question was, can we get nursing credits for this webinar, which I believe would be a no.
Okay.
So I can answer that one, unfortunately. Right. No credits for this one. And somebody is asking if they can have a copy of the PowerPoint.
Okay, sure.
Yeah, and so if it's okay with you, they can email, well, your email address is up on the screen.
They can email me. Or education, right? education@priorityconsult.com.
That's right. Does Priority Consult have its own survivorship plan? Yep, Oncology OnTrack does have that, and you actually showed it during the presentation. So maybe they asked the question before that.
Right.
All right, it says, the next question is, how do you handle private offices and getting information and cooperation?
Okay. Private offices, so I'm assuming maybe that you're talking about private offices like a private medical oncologist and getting information about what happened during the treatment process, et cetera, as well as their recommendation about surveillance. So, you know, one of the things that I recommend is if you do have outside private providers, medical oncology, breast surgeons, general surgeons, surgical oncologists, radiation therapists, radiation therapy, then in order to get their buy-in, so to speak, then I do recommend that you form that multidisciplinary, you know, survivorship committee that reports to the cancer committee, and put, you know, and ask, you know, I say put them on the committee, but ask them to be part of that committee so that they have a vested interest. And we have a client right now who's talking about, you know, building a survivorship clinic, and one of the things that they do have a private office. Their office is a medical oncology group, a large medical oncology group that does provide about 95% of their medical oncology services. And what they're doing is joint venturing the survivorship clinic with that private group, where the clinic happens on the campus of the cancer, where the cancer center is actually in the cancer center building, but the medical oncology group provides the non-physician practitioner to the survivorship clinic. They lease that provider to the hospital. So there are a lot of ways to get that, some private groups to participate and to get to make it easy for them to want to provide information.
Okay, thanks, Kim. We have another question here. How do you make plans for 3,200 new patients annually when you have only 3 navigators?
That's a great question.
I guess, yeah. Hire another navigator.
Yeah. Are you saying? I'm thinking that maybe you're saying new. How do you make for new diagnosis patients? So we'll talk about both. So how do you make plans? Well, that is hard with only 3 navigators to fit those patient appointments in. Sometimes they are more abbreviated appointments than we want them to be, and so they do end up being an initial face-to-face appointment and a lot of follow-up phone calls. But one of the other ways to make that easier is for the nurse navigators to host group appointments and to group them by tumor site, because many nurse navigators find and we hear that the patients do learn a lot from their tumor site peers. Sometimes they learn things that we wish they didn't, but they say they really like that. And we've even had patients in some focus groups that we've done tell us that they wish that infusion centers would group their infusion chairs by tumor sites so that they could sit together. The prostate patients want to sit together, the breast patients want to sit together, the lung, etc. We do find that they want to have that option because they want to share. If they do want to share, they really want to share tumor site specific. So those are just some of my thoughts. And then, of course, as it relates to survivorship patient appointments, you certainly could do that too. You could give them an initial visit that talked about their own individual survivorship plan, and because of course it's full of PHI. You'd need to have that confidentially, but you could certainly invite them back for a larger session where the nurse navigator provided general information about late effects or about compliance with the survivorship plan that did not entail any discussion of PHI. And that way, you can have 10 people in the same room and they do feel like that they are getting their questions answered.
Okay. Is that
answer?
Okay. We have another question asking, would a survivorship care plan specific to radiation therapy given to the patient upon completion of their radiation treatment meet the standard? It would include a treatment summary, dose given, potential late effects, surveillance, contact numbers, etc.
That's correct. That would be a complete. And most of them, when you look at a sample, it has, so the Journey Forward example, the ACoS example, the Oncology OnTrack example, they all have what is required to enter about each treatment type. So, for example, about dosage and number of regimens, etc., biologic type, etc.
Okay. The next question is, what is the expectation of the CoC for what cancer patient populations / disease sites have a care plan? We only have a navigator resource for breast cancer. How do we accomplish without a dedicated navigator for all other cancer sites? We also have all private med-oncs and surgeons.
Okay, great question. So of course the CoC's expectation is across all tumor sites, not just for the tumor sites where you have a dedicated navigator. So that does make it harder for you to be able to be compliant. That means that that terminal provider, that primary provider, has to take over the requirement and bear the burden for your center and consequently your accreditation. They have to bear the burden of providing that plan. For me, that would be another reason for you all to think about an organized survivorship clinic, so that your control, if you will, over the provision of those survivorship plans is under the guidance of your greater cancer program, as opposed to your individual participating providers, whether they be inside the cancer center or private. It just gives you more control, which of course I'm sure your medical director for your cancer center, your registrar, and everyone who works, your oncology leader, who work on your maintaining your CoC accreditation, they probably feel like that the more things they have control over as it relates to that accreditation, the better. And and this certainly would be no exception.
Okay. Next question is, we have people who are only diagnosed at our facility and they receive surgery or treatment at another facility. Who will CoC require to have survivorship plans? Does that make sense to you?
It does. It makes great sense. Okay, so if you look back, let me see if I can go back to... Okay. Here we go. Okay, so if you go specifically to standard 3.3, they do not talk specifically about whether these are all analytic patients, but my guess is that the plan that is created by your cancer committee, that for standard 3.3 includes a plan for all of your analytic patients. So essentially that means that you say that you have encouraged your community participating providers to provide the patients with a survivorship care plan. You have provided them with the links that are to the ACoS plan, to Journey Forward, to the Institute of Medicine and their flyer. And so for the patients in your community that are represented in your registry as analytic patients, that that your cancer committee has made strides to make sure that that survivorship care plan is available to the patients. Okay, so if you go down here and look at monitoring compliance, what they're looking for is the cancer committee has developed a process, and each year the process is monitored and evaluated. Okay, and so if you are in that predicament, like that the person who put that question out there, where you really have no control over the execution, the actual provision of a paper plan to patients, that you're at the mercy of those private groups, then all that your cancer committee can do and all that your CoC surveyor can see is that you have a process where you advocate the provision of a plan. You have sent out letters from the cancer committee to your participating providers as represented in the registry. and you you've handed them on a silver platter access to those locations where they can easily create a survivorship plan. And if you've gone so far as to create a survivorship clinic for your diagnosed patients, then of course you've advocated that they refer those patients there. But all you can do, and all that you're required to do, is to create a process and begin to monitor it. Now, in the next coming 3 to 5 years, we'll see what happens with CoC. Do they start to base compliance on how many patients are actually handed a survivorship plan, and whether or not there is adherence or compliance with that plan? I think we'll see that in the years to come. But today, it is only that you document that you have a process and that you are monitoring that so that you can make decisions from that monitoring information.
Okay, Cam, the next question, let me know if the answer you just gave would apply to this question as well.
Okay.
But this person says, the standard seems appropriate for academic centers that have all treatment under one umbrella, but having difficulty figuring out what is expected of community hospitals with large cancer patient volume, but really only provide surgical treatment. Other treatments are done by private practice.
Right. So I think, yeah, I think what I just said earlier does apply to that. As the Cancer Committee just needs to do the best they can to create the process, communicate out to those other providers, and advocate that a plan be created with one of the resources that are nationally available, or if there's an internal resource like Oncology OnTrack.
Okay, and then a follow-up to the question before about the radiation therapy.
Mm-hmm.
They say, so are you saying that it can be specific to a radiation oncology center and would not include treatment summary or specifics related to surgical or chemotherapy intervention?
No, it would need to be the treatment summary would need to include all treatment that the patient had, not just their radiation therapy. I'm sorry, I may have misunderstood that question. I thought they were asking what components of their radiation therapy needed to be included in the treatment summary. But a survivorship plan treatment summary would be incomplete if it only had information provided by a radiation therapy center.
Okay, well, they go on to say that they're not realistically able to obtain this information from private practitioners. They have no funds to establish a clinic for survivorship, and they're having challenges holding on to current resources for cancer. So,
okay. Yeah.
I don't know if you can relate.
Well, I think, yeah, we can all relate. I think, the answer then just is to have your cancer committee do their very best to create the process, to advocate for survivorship care plans in the community, and do their best to do that monitoring so that, if non-compliance is happening in their market, then at least they can document it back to those providers, and perhaps the documentation of that non-compliance, once you have the data, that certainly might be, a point that would turn some of those private providers on a dime to have them maybe be more willing to come to the table and share information. So that a patient can get a cohesive care plan.
Okay. Do you have time to answer a few more, Cam?
Sure.
Okay. The next question is the survivorship plan a reimbursable charge for insurance?
Great question. The answer there is not a CPT code for the provision of a survivorship care plan, but depending on how you have set up your nurse navigator or the billing for your providers, then depending on if the nurse navigator is providing the survivorship care plan, some of our centers include that in the determination of the E&M level for the facility part of their charge. If the nurse navigator is part of the facility, and that is a great way for you to have some reimbursement associated with the nurse navigator's execution of a survivorship care plan. It's of course not a professional charge, but as I said, it's part of the facility portion of an evaluation and management code. Or if it is a provider or a non-physician practitioner, then of course it is reimbursable, and we recommend that you, as an evaluation and management code for an established patient, and we recommend that you code for time in counseling and coordination of care in the provision of that survivorship care plan.
Okay, great.
Mm-hmm.
The next question is, how long after treatment do you see patients being turned over to mid-levels or other providers in a survivorship model? I know it may vary by tumor type and other factors, mm-hmm. but what is the general time frame?
So the general time frame is, that they're turned over to a survivorship care plan, within the first, 6 months of completing their active treatment plan. And then they can stay in that survivorship clinic, infinitum. And even for the recurrence patients who are in the survivorship clinic, have a recurrence, leave the survivorship clinic and go back into active treatment, back to their active treatment provider practices, they can come back to the survivorship clinic for a second go-round.
Okay. The next question is, do you recommend a navigator to be a nurse, layperson, or survivor?
Oh, great question. I recommend that the navigator be a nurse. However, a great team is a navigator that includes a nurse as well as a layperson, so that the licensed practitioner, the nurse, can be the provider of information that is clinical. But then the layperson can be the partner provider to that nurse navigator to help with those questions that are not clinical. And we see that working incredibly well. Those are questions about appointments, questions about what to bring to a visit, and some of those can be they can be questions about access to support services like transportation vouchers or psychosocial support. So many nurse navigators will tell you that they spend a lot of time talking to patients about getting access to services, getting access to financial counseling, or talking to patients about their own medical coverage, which didn't require their RN or BSN, and that really could be done by a layperson who specializes in navigation. And so in those instances, we recommend that you hire a layperson to do that, but educate that layperson on the components of navigation with something like the Harold Freeman Patient Navigation Institute, which is an online course, so that that layperson can receive accurate training on how to provide navigation. They can be the one to do this, what can be tedious data entry, but of course have that reviewed by a licensed provider.
Okay. The next question is if you can comment on the number of navigators needed per patient or per number of patients for survivorship.
Well, so it depends on, if your survivorship coordination is on a one-on-one basis, then I would say it typically runs, one, and this even is the case for, I even recommend this as it relates to treatment. one navigator per 200 patients is typically what is a manageable workload. One navigator per 200 patients.
Okay, great.
Mm-hmm.
Okay, scrolling through the questions, I believe that we've covered all of them.
Okay.
And so if anyone does have any questions that were not addressed or that come up to you, please, again, feel free to email us. I've received a few emails already asking for the PowerPoint,
Okay.
and I will get that sent out later on this afternoon. So, Kim, thank you so much. Obviously, this was a very relevant topic for everybody, and it was very well attended and informative. And the recording will be placed on our website as well, in case anyone wanted to refer anyone else that wasn't able to make it to the recording. So thank you, Cam, and thank you all for joining us today.
All right. Thank you so much. Everyone have a great Easter weekend.
You too. Thanks.
Bye-bye.
Bye-bye.